Good afternoon. Sorry for the late start. We had some technical difficulties, but the Maryland Healthcare Commission thanks you all for joining today's webinar on remote patient monitoring, Medicaid new rules, and pediatric asthma projects. This is the third session in our multi-part series of learning sessions focused on implementation and sustainability of telehealth. We are very excited to bring you today's webinar highlighting key topics of remote patient monitoring. Our hope is to provide more in-depth information on the new RPM Medicaid billing opportunities, specifically the requirements, qualifying conditions, and restrictions, and an on-the-ground RPM deployment experience. The second presenter is an MHCC Telehealth Grant awardee, and we thank them for their continued commitment to providing valuable information to the telehealth community and sharing their lessons learned. We have selected these presenters as they provide different perspectives and knowledge on RPM. Before we get started, I would like to cover a few housekeeping issues. First, we are recording this webinar to make available to those who weren't able to participate today. Second, at this time, all webinar participants are in listen-only mode to limit any background noise during the presentation. After the presentation, we will have a 15-minute Q&A session. Participants who have questions should include their question in the question window, and my colleague will read these out loud to the presenters at the time of the Q&A session. So our first presentation is from Dr. Tiffany Wedlake and Monshel Pridgett from the Maryland Department of Health Office of Health Services. Dr. Wedlake is the Medical Director of Maryland Medicaid Management Care, and Ms. Pridgett is a Health Policy Analyst advanced for Health Choice and Acute Care Administration. So over to you, Dr. Wedlake and Monshel.
Good afternoon, everyone. Thanks for joining us today. I do not have control of the slides, it looks like.
So you do not, but they should be up, and I will be advancing the slides.
So today we'll go over the coverage for remote patient monitoring, just making sure everybody understands what is included in remote patient monitoring, the prior authorization requirements that are going to be effective for the health choice population, our coverage information, billing information, and then we can answer some questions. So remote patient monitoring is using digital technology to monitor patients who are in their home or other location and transmit it directly back to their providers, their physicians, to be able to monitor and then be able to use that information to do different assessments and interventions with the goal of keeping patients who might otherwise be at risk for repeat hospitalization out of the hospital. So it's providers who can prescribe remote patient monitoring, particularly things like home health agencies, physicians who work in health, federally qualified health centers, other physicians, managed care organizations would need to work with a physician to do it. They couldn't directly order it themselves unless they're also a provider, but clinics and hospitals would be able to do it as well. So remote patient monitoring is done when it's necessary to improve chronic disease control, and it is really evidence-based only for the purpose of reducing excess hospital utilization for patients who have had already excessive utilization of the hospital due to poor disease control. It can potentially prevent these readmissions from occurring and the repeat visits to the ED from occurring. Here in Maryland, we will be approving remote patient monitoring for 3 conditions, or 4 really: diabetes, type 1 and type 2, congestive heart failure, and COPD. So in order to qualify, they need to be Medicaid recipients. The individual must consent to do the remote patient monitoring. They must have the ability to do that in their homes, meaning that they must have internet connection, and they must have the ability to use the monitoring tools within their home. They must also have qualifying diagnosis and qualifying events. And the qualifying events would be at least 2 admissions for the same diagnosis in the previous 12 months, 2 ED visits for the same diagnosis, or 1 admission and 1 ED visit for the same qualifying diagnosis in the previous 12 months. Again, the whole point of this is to help improve chronic disease control in patients who have poor control. And the poor control is demonstrated by the fact that they're having to go to the ER or be inpatient for that disease. So in order to do the prior authorization, we do have a standard form for the Maryland Department of Health. This is for the fee-for-service. The MCOs might have different versions of the form. So you would enter the information. Part of one of the things that's a little bit different here is the rendering provider information is on here, along with the provider who might be doing the ordering. So you do have to mark which diagnosis is the qualifying diagnosis and provide the exact ICD-10 codes that were used. In addition, the qualifying events. And then we request that the provider who's ordering this attest that they do believe that this is appropriate, that they're not already getting a similar service. You know, if the patients are already getting in-home nursing or other skilled care, they may not need remote patient monitoring. If the patient's not felt to be at risk for repeat hospitalization, then they should not be getting this kind of monitoring. The patient must have the ability and willingness to use the equipment. They must not be residing in a hospital or a nursing facility. This is for in-home, not for institutional monitoring. The ordering provider, if they're not the rendering provider, will need to make sure that the rendering provider is able to monitor the values and is reporting them back to the ordering provider, and we'll be checking it for immediate notification. So this is supposed to be like daily monitoring. This is not supposed to be you send in your information once a week and somebody looks at it. This remote patient monitoring is meaning that there is a provider reviewing those numbers every day, and when there's something abnormal, able to take action for that. So remote patient monitoring will be approved in episodes up to 60 days, and a single individual may receive up to 2 approvals within a 12-month period of time. So the limits do apply across provider types. So you cannot receive 2 different episodes of remote patient monitoring from a home health agency and 2 episodes from your cardiologist. You would need to have, it's the limit of 2 episodes of up to 60 days is per calendar year across the different types of providers you might order this, and across the different conditions. So remote patient monitoring can be reimbursed for up to $125 per 30 days for monitoring, and that is an all-inclusive fee. That fee does include the supplying of the equipment, any training that needs to happen for the patient to be able to use the equipment correctly, and the actual monitoring that's being done. If a physician is monitoring a patient, for example, for 60 days, they would be reimbursed a total of $250 for that episode of care. Again, that does include the installation of the equipment, educating the patient how to use it, and making sure the patient is able to transmit it if it's not done automatically every day, including the interventions that would happen based on the abnormal data. It does not cover purchasing equipment or upgrades to equipment. It does not cover internet service. Again, it's important that the patients have the ability to use the equipment, and that would include that the equipment could be used in their home because they already have internet, or maybe the equipment does not require internet and it can transmit wirelessly. But this benefit will not pay for internet to be installed in the home. So this is the HCPCS code that should be used. It's S9110, and it is reimbursable for remote patient monitoring for the different provider types. And 0581 is only for home health agencies. So if a home health agency is doing it, they're the only ones that can use that code. It is important to remember that the MCOs may have different prior authorization requirements in addition to what we've gone over today, which is the fee-for-service requirements. They do typically have requirements that are similar to the fee-for-service requirements, but they are allowed to have additional ones, and they may have other criteria involved. So you should contact each MCO about any specific remote patient monitoring requirements or prior authorization limits. Look on our website for more information, and here's a link to it right here. I believe you guys will be able to get a copy of the slides if you don't have time to write this out.
We also have another version of the presentation that includes the MCO contact information as well as the contact information for the home health side and the side for other professionals if you would like more information. We can share that with you when the webinar is over.
Great, thank you so much, Dr. Wedlake and Ms. Bridget, for that valuable information. Our next presentation is from the Johns Hopkins Home Care Group, Pediatrics at Home Services. The Pediatrics at Home is piloting a comprehensive program that provides enhanced disease management to children with asthma through the use of a mobile application. So our presenters are Susan Huff, who is the Senior Director of Pediatrics at Home, John Adamovich, who is the Administrator of Business Development and Innovation at Pediatrics at Home, and Melissa Lentz-Garnish, the Monitoring Program Administrator for the Johns Hopkins Home Care Group. So whenever you're ready, guys.
Good afternoon, and thanks for joining us, everyone. And I want to especially thank the Maryland Health Commission for giving us this opportunity to make this pilot available to patients and families. So this was specifically a feasibility pilot, meaning that when we presented our idea and our concept to our health system and to other payers, one of the biggest questions they had was, is this going to be feasible? Will children really be engaged in this type of mobile application? If you can go to the next slide, please. Thanks. So we're going to talk a little bit about, this is our agenda today, obviously going through the program, focusing on strategies that have really made us successful in this endeavor over the last couple of years, talking about our benefits and our metrics to date, and then considerations for future deployment. Next slide. I wanted to just give you a little bit of a background of our company. We are Pediatrics at Home is a pediatric company within Johns Hopkins Home Care Group. We're part of the Johns Hopkins Health System. We are a comprehensive company, so we include home-based services, meaning home health services. We also have an infusion company, durable medical equipment, clinical respiratory services. We serve the central corridor of Maryland and Washington, D.C. Why did we choose asthma? So this is something you obviously need to ask yourself for any type of remote monitoring program that you're trying to develop or have an idea about. We already have remote monitoring division. This program did not sit within our traditional home health model. We see many new asthmatics in our home health model, but it's not perfect, and we have problems with some of these patients, particularly finding them, and the fact that patients with asthma usually respond acutely, not more on a chronic preventative basis. And so one of the first things we asked ourselves is, are we able to do this for children, and why would we want asthma? First of all, we've always been very interested in stepping outside of the traditional home health box to look at models, and we've been very proactive in developing adult models for CHF and COPD, but when we came across all the different companies offering remote monitoring equipment, there was really nothing for pediatrics. And that brings us to our problem within our health system and with the state of Maryland and the country, is that asthma is not only an expensive cost to any payer or any health system, but it has major impact to the patients and the families' lives. And this has multiple reasons. So in our health system, it's the second leading cause of admissions to the Children's Center. So I wanted to really be creative in trying to address some of this outside of the scope of traditional home health. What we had an idea was to look at a mobile platform that could really increase access to where the patient was, because one of our issues was that especially adolescents, they're everywhere. They're with one parent, they're with a grandmother, they're with friends, so pinning them down as to where they are was a big issue. And so I thought, communication, what better way to communicate with children and adolescents is through cell phones, because they all have them. And so we found, which was really important to the project, a vendor that was a startup company, Quantified Care is their name, and they became our partners. We presented the idea to them, the concept, and asked them to help work with us on develop this technology. And that was very important, because finding a vendor who wants to commit and collaborate is not easy, and it has been a very good partnership. Next slide, please. This just is an introduction. You obviously, I'm speaking now, and then Melissa Lansgarnish will be speaking, and John. But Mike Batista is the CEO of Quantified Care, and Leslie is our respiratory therapist, who also is one of the clinical leads in the program. And all of us from a team have made a commitment over the last couple of years and met on a weekly basis to improve this program and to refine this model and to make it successful. Next slide.
Hi, everybody. This is John. So just wanted to kind of kick it off here with the beginning of our strategies, and that was doing an environmental scan. So really what we realize, as you all know in healthcare, is there are multiple stakeholders. So you need to really start to look at data from a number of different perspectives in order to start to advance your program, especially when you're building something from the ground up and you're seeking funding through grants. So what we really started with here was on a broad spectrum. You can almost imagine this being an upside-down triangle or a funnel, starting out broad and getting more and more specific. But we did a national, state, and city data scan to really get a sense of, is asthma truly a problem in our area? Is our hunch correct? Or is what we see in our daily, day-to-day correct? And really the answer to that was yes. So I won't go through every line here, but some of the things to point out are really that from a prevalence standpoint, you see that Maryland as a state is much higher than the national average. In fact, we saw a graph from, I think, 2010 data showing that the national average was kind of holding steady and Maryland was getting worse, and that Baltimore City was a large driver of that. So we knew that, what we saw in our day-to-day operations wasn't indeed correct. And then from a social impact, patient missed school days is a huge factor, about double the national average. And then also, your cost of productivity loss per year when a caregiver has to take off work to care for their child who's having an asthma exacerbation is also a really significant number. Lastly, the medical impact. So thinking now to, when we go to make this a sustainable program and want to take us to the payers, this is something that they're really going to be keen on, as well as our hospitals. So you can just see that there's a big impact here for the use of the emergency department and hospital. As Sue said, is the #2 cause of admissions to Johns Hopkins Children's Center. So that said, trying to take a big scan here, identifying data that would be eye-opening to our grant sources, and then as well as the payers. Then next, trying to refine this, going to do surveys and focus groups of our target population. So we actually were able to conduct a survey at one of our referring sites. It's East Baltimore Medical Center. And just to actually make sure that would these patients and their caregivers be interested in using a phone or a smart device, if you will, to participate in this program, and then also if they are, do they have ownership of that device? Because really this is a bring your own device program. We're not providing the equipment in this instance. And if they don't own it, do they have daily access? And what we found was age groups 5 to 21, 75% of those in the survey had their own smart device, and 100% had daily access. And then again, that 75% actually were very interested in using this program. So we took these two data elements and then brought it to our third stakeholders, which are the referring physicians, to say, hey, look, you know this is a problem you see with your patients. We have data to prove it. We also have data now that proves that your patients might be interested in this type of a program. So let's see if we can build something together. So if you could go to the next slide, please. The next thing that we really started on was after confirming that we're onto something here is working with our technology partner, Quantified Care, truly in weekly meetings since the fall of 2015, which was something that can't be understated enough, is having a group of people that are willing to meet weekly, knowing that this is going to be a long process, but something that's very beneficial in the end, and really making sure that we're driving this program forward. So if anybody's heard of rapid iteration improvement from a quality proponent or human-centered design, where you're constantly refining the product, it's kind of some of the approach that we established here. So we started with the data gathering, which we just went through, so utilization data, participant willingness and ability, then started to develop clinical workflows. So one thing that we knew is we shouldn't be trying to reinvent the wheel. Rather, we wanted to take clinically accepted and established guidelines that are used across the nation, so they're valid tools, and then we really just digitized them. So namely an asthma control test, which we conduct weekly for symptomology, or sorry, that's a monthly questionnaire, and asthma control symptomology questions are done on a weekly basis. So really, developing those clinical workflows, and then having our tech partner sit with us to design two items for us, really, from the user interface perspective. So you have what the patients and caregivers will be using on their smart devices, namely an app, and then what our clinicians here, our registered nurse and respiratory therapist, use on their laptops, which is a web portal, to communicate with our patients and make sure that they are monitoring their patients in the most productive way. And then lastly, algorithms to help identify which patients need to be followed up upon. So a really big iterative process, back and forth, lots of work towards that. Once we had a nice little prototype working, we would take that to the payer groups to conduct demos, to try and establish what are your needs to make sure we can get this program up and running, make sure we're driving some sort of an ROI to them, and to show them that we've done all this work as a sign of goodwill, that we're really in this for the long haul. And in parallel to that, using this work that we've created to start identifying and writing to grant sources. So fortunately for us, we were able to secure funding from the Maryland Healthcare Commission, and then also another funding source, the ABLE Foundation, which is a local Baltimore City organization. If you go to the next slide, please. So strategies for deployment. So we just talked about pre-deployment. Now we're going to go into actually getting the program up and running. So the first item here is training. Something that is really nice is our technology was pretty intuitive, but what we had was essentially our tech team came over, trained our clinicians not just on the web portal that they would be using, but also in a way to teach their patient and caregiver, once they onboarded onto the app, how to use that. So basically, you're kind of doing a teach the teacher moment to really make sure we all know how to use this technology, and then once our clinicians are in the patient's home doing an environmental assessment and onboarding the patient, they know how to troubleshoot and upload and get everybody up and running on the mobile side of the platform. So from the implementation standpoint, we also utilize marketing materials. So we developed those, had those approved by the IRB, because this is an IRB-approved study that we plan to publish the results upon. Then we went out and got those to the physicians, put them in the physician team's hands, put posters up in these physician offices as well, and in addition to education materials for the patients. So really trying to make sure that we are promoting this program as well and actively promoting it. From an evaluation standpoint, really that's something going back to the previous slide where with those weekly meetings, once the program is underway, we would have weekly feedback from our clinicians, bring it back to the tech provider and vice versa, really trying to refine this program on the fly and make sure we're operating this as efficiently as possible. So those were weekly meetings. In addition, we also had monthly meetings with the MHCC, which was really great because it really held us accountable for what we set out to do, especially with the assigned metrics that we gave ourselves to make sure that we're striving to achieve those metrics. And that leads us into our outcomes, which Melissa will go into in a second here. But really, there's no point in running a program unless you're tracking the data and the improvement that you can generate, especially as you're trying to create a program that's scalable and sustainable. And that really leads us to our last bullet in terms of funding. So this is something that's purely grant funded right now, but we are seeing some really promising outcomes that we think will entice payers to carve out and make sure that this is a program that is available to much of their populations. If you can go to the next slide, please.
Hi, everyone. This is Melissa. This is really a concept slide to really just let us focus on the patient and caregiver, as that is the center of the focus of this entire program. The patient with the remote monitoring, the self-management and education part of this. We had collaboration with physician, whether it be primary care physician, the specialist, or the hospitalist. Also, this can extend to payer collaboration, hopefully reimbursement in the future, and care coordination with the payer case managers. And if need be, with our home care partners. With this program, we did not have to cross over into home care with any of these cases, but the potential is there in the future, and that could happen with these type of patients. In the picture, you'll see the device in the one patient's hands, the remote monitoring system on the portal side at the clinician side, and some information on the patient side. Next slide. Some benefits to this program have been increased access. The Bring Your Own Device has allowed for an easy way for us to provide one-on-one attention to the patient. As John was mentioning in his talk, 100% of our patients had daily access to technology, which probably isn't surprising to many of you, but all of our patients has access, so it was very easy for us to be able to capture this population. The technology is allowing us to scale this type of program to our clinicians to touch more patients, because we are remote for these patients. We're not doing inpatient visits. So part of the advantage of monitoring patients remotely, you can see the patient without actually being there. So you can scale, you can see more patients easily. The ability to get patients into primary care appointments when our patients are having trouble when they're checking in on the device, and we see that they're not in the green zone where they should be, if they're starting to have trouble. We had easy access to get them in to see their physicians quickly. We also found that many of our patients' asthma action plans are required by many of the public schools. However, our patients, we noticed, did not have a lot of these asthma action plans, or if they did, they weren't really sure how to use them. So we were able to get them into the hands of our patients and caregivers and help them understand how to use them to more effectively manage their asthma, and if they were starting to have an exacerbation, know what to do, know what medications to use. So that was a big eye-opener for this program. This allowed us to communicate with the patient or caregiver however they preferred, through this app. We were able to relay pertinent information to the care team real time. When the alerts came across, we do check this, the portal for these patients on a daily basis, many times a day. So whenever the patients were checking in, we were able to see if there was a patient having an issue and communicate real time with the patient and caregiver, and also back to the physician, so able to take care of an issue when it was happening versus waiting for the patient to possibly go to urgent care or an emergency room or actually be admitted. We could proactively intervene before the issue became more serious. We were also able to reinforce age-appropriate medication education. Because of the focus groups that we did, the kids, we knew we had different, the app could interact with the children within the different age groups, how they like to be spoken to. So some of our younger kids liked emojis and things like that. So we were able to interact that way and have them understand what they were learning from the app and gain their education in different ways depending on the age of the child. We were able to get supplies to the patient. A lot of these patients didn't have their nebulizer machines or tubing or spacers, and weren't even able to take their medicines as ordered. So we were able to really interact with that and make sure that they had the tools that they needed to be successful at home and manage their asthma. Next slide. So now we're going to look over our outcomes data. So the patients we were looking at were from ages 5 to 21. They were referred from our Johns Hopkins Community Physicians sites within the Baltimore City area, from Canton Crossing, East Baltimore Medical Center, and Remington sites. The patients were on our service for about 90 days, and at that time they would graduate. We found many of our patients that had graduated were still checking in on the app because they did like the interaction and the information coming from it. We had 77 patients total in the program. 98% of those patients were part of a Priority Partners, which is a Medicaid MCO. Of the 77 patients that were enrolled, 87% use the app at least 4 times per month, with reality about 8 to 9 times per month each patient was checking in. We asked them to check in 4 times per month and every 30 days. So the engagement in this study was tremendous. Looking back at the 90 days, we did a 90-day look back, so pre-enrollment for 90 days, and then 90 days post-graduation. We had an 80% reduction in emergency room visits and hospital utilization for the entire population, even for those patients who haven't graduated. And then we are also looking at 180 days pre-enrollment and 180 days post-graduation. So far, that rate has shown to be a 53% reduction in emergency room visits and hospital utilization for the entire population. That number is not complete yet because we're not 180 days post-graduation for many of our patients. Our last patient will disenroll at the end of this month, so we still have some time to look out for that. But the numbers are looking promising to show a significant reduction in hospital and ED utilization for that. Our next comparison that we do want to look at is season to season, because oftentimes asthma is impacted by seasonality. So that will be our next thing to look at, is comparing the season that the patient was on and looking pre and post that. We have done surveys with our patients when we set them up, a pre-survey and a post-survey. And as you can see in our data, the patient caregiver satisfaction has been 98% to the positive. And next slide. So this is considerations for Medicaid. With Medicaid, currently this program is not reimbursable under Maryland Medicaid. As they just said, this is not one of the conditions that they are reimbursing at this time. So our goal is to work with Maryland Medicaid, and we would love to expand coverage to include the care of children with asthma via remote patient monitoring program. And that's what we have.
Great. Thank you so much, everyone, for the wonderful presentation. That was great. So we will now open it up for questions and answers. So please give us a moment as we review the posted questions. As a reminder, if you have a question, please answer the question in the question window. My colleague Angela will read them aloud. If we don't get to your question, we'll be sure to share with presenters and follow up with you via email. Angela?
Great, thanks. So the first question, I believe, is directed to Medicaid. Can the remote patient monitoring solution be used or transmit the data over an audio line or only over internet?
So it would depend on which technology is being used. I mean, not over a telephone. That wouldn't be patient monitoring. It would need to be, it's actual data that needs to be transmitted, not just a conversation. So you would, it's like pulse oximetry data and glucose monitoring data, weights, blood pressures, other remote monitoring. But so if there's a way of transmitting the data, but you can't just call and give a report.
Got it. Okay. And feel free for the folks who proposed these questions, if there are clarifying questions, please post and we'll get to those as well. So the next question, I believe, is also for Medicaid. What if the patient is monitored for 45 days or 55 days? How does that get billed?
So it's billed in 30-day increments.
Okay. The next question again is for Medicaid. Is there something other than O2 stat that can be used for COPD?
I'm sorry, can you repeat the question? O2 staff?
Stat, S-T-A-T. And if you need more clarification, just say so. And
like O2 saturation that would be used for COPD, they could certainly use. They might be doing, expiratory volumes but primarily O2 is usually what's used for COPD. I mean, it would be up to the provider that's ordering it to decide what all they need to monitor. That's true for any of these. The provider who's doing the ordering and will be doing the monitoring will need to decide what they're monitoring based on because they're going to need to be doing interventions based on what they're monitoring. The whole point here is to be able to do that remotely without having the patient come back.
Got it. So the next question is for peds at home. What clinical equipment did you use to determine if the child is on the edge of having an asthma attack?
That would be based on their responses to their asthma action plan. So the questions and related to the asthma control test.
So every patient that has asthma has an asthma action plan, and we digitalized it to put it in the app so that it's actually used much more than it ever has been before. And those include orders from the physician. So you see different responses, whether
symptom responses
according to whether they're in the green zone, caution would be yellow, or severe would be red and alert. And Melissa works that with those physician orders that are in the asthma action plan and with the patient.
And the reason why we didn't use things like peak flow or spirometry, we actually set out to incorporate those, and they're optional inputs. However, from the pediatrician standpoint, we heard that data couldn't be trusted as much just because it's tough to know if somebody, especially if they're younger, is using those devices accurately and if they're using them enough. So they really look to base their decision-making on symptomology, and that's why we also went for symptomology too.
Great.
So we also,
oh, go ahead.
we also had a follow-up to when the patients, if they were having an issue, we had developed something called a SMART asthma action plan. So very similar to the asthma control test, they could check back in with symptom questions, and they were weighted in a certain way to bucket them into different categories, whether they were green, yellow, or red zone, to have additional follow-up after they were having a condition or a problem so that we could follow up with them. And that also had physician orders linked to it to determine their next step.
Right. And I think a similar question was asked around using a peak flow, so I will skip that one. And a related question, what devices were being used for Pete's at Home, and I think you guys clarified that that is mobile devices.
Yep, whatever mobile device they
whatever device they had.
It just had to be a smart device, so it couldn't be a flip phone, but it could be something like an iPad or, you know, a Samsung Galaxy phone, things like that.
Right. And again, just to reiterate what my colleague Ava mentioned, we are planning to share the slides after this presentation via email, and they will also be posted on our website. So moving on to more questions. We have a question regarding billing. Can remote patient monitor be billed during a home care episode by a home health agency? So to clarify, can the bill for both home care and for remote patient monitoring?
So one of the criteria for remote patient monitoring is that they are not receiving similar services already. So if they're already getting home health care, getting somebody to go in and do interventions for them, then they shouldn't need additional monitoring in the home. Like, so that's what the purpose of remote patient monitoring is, to get access to patients who aren't getting services in the home, so that you can get data from them to help and do interventions with them, to then order interventions, so that way they don't end up back into the hospital. So if they're already, and so home health certainly can be one of the people who does remote patient monitoring, but if they're going into the home to do home health care, then the patient would not qualify likely for remote patient monitoring.
Thank you. Moving on, other questions. We have a question for Pete's at Home in terms of providing incentives to participants. Can you talk a little bit about that?
Incentives.
So for this feasibility pilot, we wanted to make sure we could recruit enough patients. So we actually did implement a gift card program, which was really there to assuage any fears about using too much data or anything like that in terms of a mobile plan. So we used to onboard patients younger than 18 years old received $25. If they were younger than 18, the caregiver got $25 as well, so all in the form of a gift card to Walmart, Target, Amazon, or Aldi. And if the patient was over 18, their caregiver would not get an additional card, and then for graduating, they would get that same amount as well. I think so. One of the things we plan to do in the future is to reduce the need for those gift card payments, although we've seen from payers that they are now starting to incentivize their own members with similar arrangements, you know, to use a Fitbit or things like that, or free gym membership. So we think we're in line, but we would like to see if there's a direct relation to the gift card incentives.
Great, thank you. So this is also a question for Pete's at Home. Can practices use this application that you've developed for children within their practice, and what is the cost for the patient? Also, is a daily web portal message sufficient for monitoring, or would we need a telemedicine visit daily?
So a practice could definitely use this. We're actually at the point of starting to commercialize this program, so we'd be happy to talk to anybody who's interested. In terms of cost to the patient, there would be no cost to the patient. It's really something that the payers would pay for this program as a benefit of reducing the use of the ED in the hospital. So that would be something that would be discussed by licensing this program from our tech providers.
And what was there was another question tacked onto that?
So I think it was just related to sort of in terms of practice. Is a daily web portal message sufficient for monitoring a patient, or would we need a telemedicine visit daily?
There's a portal that you monitor daily. Then you would monitor the group of patients.
So there's not a daily video telemedicine monitor at all. It's all done through a portal in kind of a text version.
Got it. So going back to the original question, we're talking about telemonitoring over telephone lines. One of our attendees indicated that there is a vendor that uses our telemonitoring company can remotely transmit over telephone lines the data. And I believe the original question was, would this be eligible under the Medicaid rules?
We didn't require specific vendors in the state for doing the remote patient monitoring. So, you know, if they are transmitting the data and doing the monitoring and are enrolled as a vendor for it, they would be a vendor for it.
Okay, so the mechanism by which that data is transmitted is, there's no requirements around that.
It's the responsibility of the provider to select a vendor to provide them with the equipment. And so long as the equipment can transfer the information wirelessly so that the provider can monitor it, we're not placing guidelines on what equipment the provider offers service, because it's not included in the
payment. So, go ahead.
We will be doing post-payment review and things like that to see what providers are doing, but we're not placing any specific guidelines around the equipment besides its ability to transmit wirelessly to the provider so that they can monitor.
Right. And the state is not paying for the equipment.
Got it. So I believe the next question is directed at Peds at Home in terms of their deployment of the technology. How is PCP or primary care providers' acceptance achieved, and if so, measured in your program?
So they were involved from the very start. Our principal investigator on our program is a medical director for community physicians, pediatrics. So he was involved right from the start with this program. He's also our medical director here. So we involved him from the start and involved the community physician sites with our idea and the concept of this. And they saw the value in it and have recognized the value that it's had for their patients since then. And I mean, they like the program. We went and are anxious to have it get bought out.
We went as a team to their staff meetings and faculty meetings, for example, at each one of the sites, took questions, gave demo, and actually got their input. What would be the easiest way to identify patients and receive referrals? So I think, you know, Melissa's first answer regarding involving them from the very beginning was key to getting their acceptance, because they really were part of creating this and were able to see the value from the onset.
Great, thank you. So this question is also for Peds at Home in terms of reimbursement. Was any part of the program eligible for reimbursement from a managed care organization or private health insurance?
No, not at this point.
So moving on to more questions. I think this is just generally, the question is, we're currently using monitoring scales, O2, blood pressure, and blood sugar. What we're looking for is whether there's a piece of an additional equipment that would help us with monitoring COPD patients.
Are you asking in general? Anyone?
In general.
Oh, pulse oximeter.
I mean, that would be up to the pulmonologist or primary care that's caring for that patient as to what they think is going to be useful. I mean, whatever provider's requesting the order is going to know what it is they want to be monitoring for this specific patient to reduce this specific patient's risk of being readmitted, because they would know what's going on with that patient. Often these patients have multiple chronic conditions, so it may vary by patient on what things they need to monitor.
Right. So moving on, can you speak a little bit, Peds at Home, about additional kinds of data that were being monitored for the pediatric patients?
So other things that we were looking at, aside from the self-reported data that came into us, was if somebody went into the ED or hospital through CRISP. So those reports would be linked back through us through their pediatrician sites to really get a sense of utilization in total and making sure we have a total picture of what the patient was doing. But Melissa, were you going to add anything?
Well, we're going to do provider satisfaction. So in addition to doing patient satisfaction, we will do provider satisfaction.
Great, thank you.
Okay.
So we do have a few more questions, but unfortunately we are running out of time. As my colleague Ava mentioned, we will take these questions back to our presenters and follow up with you directly via email. So just look into your email box. That'll be coming soon.
Great. And so just to close things out, the Maryland Healthcare Commission thanks you for attending today's Lunch and Learn webinar. As Angela just mentioned, we'll be sending a copy of the slides today. In that email, you will also find a link to a very brief post-webinar questionnaire. Please take a couple minutes to complete the questionnaire. We would really greatly appreciate it. Responses are extremely helpful to us to continue to make our webinars better and help MHTC in planning the next Lunch and Learn webinar. We are most interested in hearing from you regarding topics that are of interest that we might highlight in a future Lunch and Learn session. So thank you again, and we look forward to your continued participation. Have a wonderful afternoon.